Okay, so I think we can begin again. So we have the pleasure of listening to Leanne again, talking about V and Q mismatch. What does it mean?
Okay, I'm going to start again. So for the next half hour, we're going to talk about some auction theory and what there should be a dot on top of the V and a dot on top of the Q, and that would suggest that we're going to talk about ventilation and perfusion. And how does that work into how we assess specifically our cardiac patients, because it's a little bit difficult at times to tell whether or not we're actually delivering enough oxygen to the tissues, because some of our children will inherently be cyanotic to begin with. So let's start at the very beginning. Once again, I have nothing to disclose. And we're going to talk about some steps in tissue oxygenation. We're going to talk about the difference between hypoxemia and hypoxia, some of the causes of hypoxemia in children, some signs and symptoms, and again, some systemic consequences. So just to remind you that oxygen is a naturally occurring substance. It has an atomic number of 8. It has an atomic mass of 16. The atmospheric pressure is 760 millimeters of mercury at sea level. And the concentration of oxygen within the atmosphere is 0.21, which gives you a partial pressure of 156 millimeters of mercury. Why am I throwing all of these numbers out at you? Well, we're going to talk about what happens when you move things from an area of high pressure to an area of low pressure. Believe it or not, that's what we do when we breathe. So let's imagine this as the oxygen cascade. We're going to move from an area of high pressure down to an area of low pressure within a number of steps. So let's take a couple of examples. The normal oxygen tension in you and I, let's say up in the air, it's 156 millimeters of mercury, right? We just said that. So here we are at sea level with a partial pressure of oxygen, 156 millimeters of mercury. We breathe that oxygen in, and then it steps down, and you are going to have a concentration gradient, and you're going to have, in turn, a partial pressure gradient. And the normal partial pressure within your alveoli is about 100 to 100 millimeters of mercury. So it will sit kind of in here. So this is in the alveoli. It then steps, again, you're going to have a concentration change and a partial pressure change as the oxygen transports across the alveolar capillary membrane into your arterial system. It then needs to have some way of transporting itself down through the body, through the capillary system, into the tissues, and exchange till you get down into your venous system. At which point the PO2 in your venous system is about 40 millimeters of mercury, more or less. All right, so that's the way it normally works. What happens when you're sick? Well, there's certain things that can happen. If you've got, we'll talk about this, but I'll just let you think about it for a second. If you have a problem with your alveolar capillary membrane, maybe it's thick, maybe you have pulmonary edema. So this becomes thickened. It's harder for oxygen to pass from the alveoli into the arterial system. If you have a problem with transport, with O2 transport, whether it's due to the fact that you have a lack of hemoglobin or your cardiac output is poor, you're not going to be able to move oxygen around so that it can get to the tissues and that you can exchange gas. Let's look at an
latest results from the third round of the Carabao. Aston Villa recorded a 3-0 win at Bristol City. Liverpool cruised on the night, while Manchester City and Holdens. Liverpool and Arsenal are set to meet in the pick of the fourth round ties in the Carabao Cup. Tottenham will face Chelsea in making it past Leighton Orient.
toxic mix. Or conversely, we had a mixed cyanotic heart disease, say you have a single ventricle physiology, and you're starting with a lower baseline. You still need to have a concentration gradient in order to move oxygen from the air into the lung, and then you need to again have a partial pressure difference and a concentration gradient to move oxygen from the lung into the arterial system. The difference is that every time you start with a lower baseline, you have less and less reserve that can go into the venous system. And at some point, that's not going to be meeting your metabolic demands. And this is when you're going to get tissue hypoxia. We'll explain this a little bit more as we go along. So there's a number of factors, but let's just talk about 4 factors that affect oxygenation in the body in general. So 4 factors that influence transmission of oxygen from the alveoli, so within your lung, into the capillaries. So if you've got ventilation perfusion mismatch, which we're going to talk about, if you've got a right to left shunt within your heart, if you've got diffusion defects, which I alluded to, say something that affects your alveolar capillary membrane, or if you're not able to actually move the oxygen around, that's going to be affecting your cardiac output. There are a number of steps in tissue oxygenation. So the first one would be that ambient O2 molecules move through the alveoli into the capillaries, and they do that just by passive diffusion, not a problem. So we're going to load the O2, and we're going to load it onto hemoglobin. If you have a dyshemoglobinemia, so if you have something that is impairing the ability of hemoglobin to carry oxygen, that's a problem. One of the things that people have to think about, especially within our cardiac population, is when we measure an arterial blood gas, we're measuring the amount of O2 that is dissolved. It's dissolved in the bloodstream. But that only reflects about 10% of the total oxygen that is available to the patient. You and I, and everybody else, as long as we've got regular hemoglobin, carries about 90% of their available oxygen. We carry it on our hemoglobin. So if you have problems, say you're, again, we'll look at single ventricle physiology. And if you are at the front end not able to load a whole lot of hemoglobin, what we're going to do is increase the amount of hemoglobin to make more O2 available to the body. You need to be able to transport this O2 around. So you need to be able to move it from the pulmonary capillaries to the cellular destination. So that's what we were just talking about. You need normal hemoglobin and you need decent cardiac output. These two things go hand in hand. So this is what we generally refer to as oxygen transport. The amount of oxygen in the blood is calculated using the formula. You don't need to memorize this formula. So it's 1.34, which is a fudge factor, times your hemoglobin, times your saturation, divided by 100, times 0.003, again, another fudge factor, and the PO2, which is a partial pressure. And it should give you, in air, in the atmosphere, about 20.8 mils. Remember, I just alluded to the fact that oxygen is carried in the blood in two forms, both dissolved and bound to hemoglobin. Diffusion of oxygen from the capillary bed, the systemic capillaries, to the tissue level is in response to metabolic demands. So this is termed in some circles as internal respiration. It's also called oxygen unloading. So oxygen will offload from the hemoglobin into the tissue level, and at the same time, as your hemoglobin passes through the capillaries, you're going to end up with CO2 that is released. Normal oxygen extraction looks a little bit like this. We're going to talk about this more in different forums, but let's just look at this. I breathe in an inspiratory partial pressure of oxygen of 150 millimeters of mercury. I breathe it in, it ends up in my alveoli at a concentration of about 100 millimeters of mercury. That gives me a corresponding PaO2, so there's a gradient here. It goes from my alveoli into my arterial system. Most people know this really, really well. It then goes along through your bloodstream, loads, unloads, and what's remaining is venous blood with a PO2 of about 40 millimeters of mercury. What does all of this mean? Well, it means that we use about 25% of the available oxygen that we have. That means that we have about 75% of the available oxygen left over. We've got a lot of buffer here. So if we, for you and I, if we increase our O2 demands, it's not a problem. We go for a run, we do something that increases our metabolic demand. Say we're febrile or we're sick. Sorry about that. It's not a problem. This becomes a problem
So Steve, we can see Leanne now on the actual webcast, but can everyone see her slides? Oh, here we go. Okay. All right, you can begin again.
Okay. Sorry for the technical difficulties, people. All right, so let's just have a quick little review about mixed venous saturations. Mixed venous, you're going to learn a whole lot about mixed venous saturations, but we use it in a lot of different ways. One of the differences between children and adults is this becomes a much better indication that it is in adults of what's going on within the whole body. And that's got to do with the volume of distribution of blood within children. This is a talk within itself, so we're not going to get into it in too great a detail. But this is what the basic concept, the basic takeaway is this. Again, there's this cascade, right? I breathe in oxygen at a PO2 of 150 millimeters of mercury. I then have it in my alveolar space, in my alveolus, in my lung, with a P, this is a big A, so it's alveolar, PO2, of 100 millimeters of mercury, so it's stepped down. It then will step down into my arterial system, and for you and I, we have probably a PaO2, so little aO2, so arterial PO2 of about 80 to 100 millimeters of mercury. The blood then circulates throughout our body and then comes back into the venous system. When we are in the arterial system, my saturation is about 98%. At rest or during normal activity, we really only utilize about 25% of the oxygen that's available to us. So that means you've got about 75% left over. That's a lot left over. So that gives you a huge buffer. So if your O2 demands go up, say you're exercising or you're ill or you're septic and your O2 demands increase, you still are able to provide enough O2 to the tissues as long as all of the other factors are intact. If, on the other hand, you are starting off with a low saturation, say you have single ventricle physiology, and your saturation when you start off is only 75%, maybe it's 70, maybe you're not doing so well. And I utilize 25% of that. I only have 50% left over. Well, what happens if my metabolic demands go up? Maybe I'm febrile, maybe I'm septic, maybe I'm upset, I'm restless, I'm in pain, and my metabolic demands go up. So I'm now utilizing 30 to 40% of my available oxygen. So if I now am in a position where I'm in danger of not meeting my metabolic demands, of not meeting my oxygenation demands, and there is a danger that I am going to start getting some tissue hypoxia. At some point, we will talk more about this because this is an important concept. It's one of the many ways that we use to assess whether or not our patients are actually oxygenating their tissues the way that we want them to. Remember that we talked a little bit about this in our earlier presentation, is that the cardiac and the respiratory system, they are friends. So if one of them is lagging behind, the compensatory mechanism will be the other system. So these cardiopulmonary interactions, they are not mutually exclusive. They go together. So here's an example. If the FiO2 say your patient's ventilated and the FiO2 is turned down very, very, very quickly, we generally don't notice this. But if the child ends up having a deficit and we don't provide enough oxygen for what they need, what you're going to see briefly until things sort themselves out, you're going to have an increase in heart rate. You're going to have eventually an increase in red blood cells. You're going to become polycythemic. And although we don't measure in children 2,3 DPG very often, we would be able to measure a significantly more amount, greater amount at the tissue level. I'm often asked, what is the difference in definitions between hypoxemia and hypoxia? So hypoxemia is the amount of oxygen that is in your blood. Okay, it doesn't take into account hemoglobin concentration or oxygen saturation, the type of hemoglobin. Hypoxia, on the other hand, is defined as inadequate O2 supply to the body or inadequate supply to the tissues. A local hypoxia could be something like a myocardial infarction or a stroke. Global diffuse tissue hypoxia means that you've got a deficit throughout your whole body. This happens in, an easy example would be in sepsis. As a general rule, we assume that if you're hypoxemic, that you're going to have concurrent tissue hypoxia. That is not always the case, but it is most often the case. Moderate hypoxemia promotes increased cardiac output, and tissue O2 needs are then met. So the compensatory mechanism is the cardiovascular system. And if that happens, you may not have tissue hypoxia because you're compensating. The converse, on the other hand, is how hypoxia may be present in the absence of hypoxemia. So think about shock or anemia, where you may have, if you've ever taken a blood gas of a patient while you're doing a resuscitation, they can have a very, very high PaO2, but because their circulation is impaired, they're not able to deliver that oxygen to the tissues. So the tissues will be hypoxic, although the patient's blood gas doesn't show that they're hypoxemic. Okay, so just although they're closely related, they are different beasts, and you need to understand that one doesn't guarantee that the other is present. Cyanosis is an interesting thing. We all know what cyanotic patients look like, and most of us think about, your grandmother that has really blue lips and she's small and frail and cyanotic and has clubbed fingers and has pursed lip breathing. So that's a description that many people can relate to. The definition of cyanosis is a clinical condition, and it's observed when the quantity of hemoglobin is reduced by 5 grams per 100 mils of blood or by 5 grams percent of desaturated hemoglobin. Because it's a percentage, this means that there are times when some of our patients are going to look cyanotic all of the time, but I'm not clinically worried. The children that have cyanotic heart disease, clearly, because that's its name, will often be blue. amount of O2 transportability, they may be hypoxic. Yet, because cyanosis, remember, it's a percentage. So patients who are anemic, they may be hypoxic, but you may not see initially how cyanotic they are. So they may not be presenting as blue, but they can be very hypoxic because they don't have enough O2 transport mechanism. Conversely, patients who are polycythemic, so who have a high hemoglobin, will often be cyanotic in various shades and versions of this, but it doesn't necessarily mean that they have tissue hypoxia. This is an interesting thought because most of the time when we think about being cyanotic, we think that they're hypoxic, but it's not necessarily true, especially within our cardiac population. So let's talk quickly about some of the causes of hypoxemia in children. First of all, if you make some technical error and you give your child an O2 concentration that is less than 0.21, you may induce hypoxemia, or in high altitude situations. That's a more common one that you might see. Obviously, if you're hypoventilating because you're not effectively breathing and your respiratory rate's low, your tidal volume's low, you're going to end up with increasing CO2, and there is only so much space. The law of partial pressure of gases states that you can only have so much. So if your CO2 gets incredibly high, at some point it's going to start to displace PO2. Then we get into the things that are notable for our population, the cardiac population. So you're going to have things that are considered absolute shunt. Absolute shunt is when blood passes from the right side of the heart to the left side of the heart without going back through the lungs, right? So there's no exposure to alveolar PO2. You can tell that this is happening because if you increase the O2 delivery, if you increase the FiO2 that you're breathing in, it doesn't increase your bloodstream PO2. It can be either anatomic or capillary in nature. So anatomic would be congenital heart defects that actually have holes. Oh, look at that. Sorry about that. Absolute capillary shunt is at the lung level, lung capillary bed level. So that would be when you've got consolidation, any of your pathologies like ARDS, COPD, pulmonary edema, pneumonias, atelectasis. This is a primary respiratory hypoxemia. My apologies for the formatting. Absolute anatomic shunt generally occurs with cardiovascular defects and persistent fetal circulation. So this is a primary cardiac hypoxemia. So this is all of the lung pathology, gives you an absolute capillary shunt, so that's a primary respiratory hypoxemia. And then when you start having anatomical shunts that can be primary cardiac hypoxemias. We talk about shunt and we talk about dead space, and this is where the whole concept of VQ matching and mismatching starts to occur. Depending upon the school of thought, but we're going to talk about just the theory. You and I tend to breathe in O2. We end up with oxygen within our alveoli, within our lung, and we theoretically should have a little bit of CO2 that we're going to breathe out. Okay, we've got normally, so this is the ventilation piece. Normally we have perfusion, and normally we have blood going by that's going to exchange O2 and exchange CO2. So we're going to breathe in and breathe out. So you're going to have respiration, whoops, sorry about that, respiration at the capillary level. This should have a ventilation perfusion ratio of about 0.8 to 1 or 1 to 1. So this is what overall the average is within your lung and your pulmonary capillary bed. If you have a scenario where you are able to ventilate, but you don't have capillary exchange, say a pulmonary embolus, or something that is blocking your capillary bed, you've got lots and lots and lots of ventilation, but no perfusion. This is considered ventilation perfusion mismatched. The converse would be if, say, you have secretions blocking your airway and you've got perfusion of that area, but you don't have ventilation. So I'll say that again. You have perfusion, so you've got, but you don't have ventilation. That's also ventilation perfusion mismatch. If you think about a right to left shunt within your heart, you've got blood going from the right side of your heart. It sort of bypasses your alveoli and goes to the left side. That's considered shunt. If you've got lots and lots and lots of ventilation, but no perfusion, that's considered dead space. Okay, so it's a continuum. Our norm is somewhere within here. So you're going to have areas with a little bit of shunt, areas with a little bit of dead space, but not too much. Excuse me. And the average is that it works for you. And that would be considered ventilation perfusion matching. Other causes of hypoxemia in children, so like we just discussed, it could be called VQ mismatching. Generally, these things respond well to oxygen therapy. So things like chronic lung disease, pneumonia, pulmonary secretions, those kinds of things, if you increase your O2 delivery, then theoretically you should be able to increase your PO2 and your patient will not be hypoxemic. This is the business that I'm in. There are times when you're going to have diffusion defects, thickened alveolar capillary membranes. We talked about this earlier. So think pulmonary edema, alveolar capillary dysplasia, things like this are going to hopefully won't be so severe that these defects will also respond to oxygen therapy. Systemic consequences, everything from digital clubbing, which doesn't happen frequently in children, to thrombocytopenia, to increasing your hemoglobin concentrations in order to compensate. All of these things are systemic consequences of hypoxia. 2,3-DPG levels we talked about, they're not common in children. Decreased level of consciousness is very common. It is an ominous sign. These are things that happen as a long-term exposure. Interesting. I'm just going to throw out some terms because one of the things that we can do is we can determine by measuring some of these things and using the Fick equation, what your VO2 is. VO2 is your oxygen consumption. So it goes something, just follow me with this. Oxygen is neither created nor destroyed. Therefore, what you breathe in plus what you use up is what is going to equal what you breathe out. Okay, so what you breathe in is going to equal what you breathe out plus what you use up. This is the equation for O2 carrying capacity, and it has a factor of hemoglobin, a saturation, a fudge factor of 1.39, a PO2, and another fudge factor. We often are looking at what oxygen extraction is. So we will know what's happening at the alveolar level. We can measure that. We can measure what is happening at the venous level. And that is going to help us determine what our O2 content is arterially and our O2 content is in our venous system. So we take an arterial blood gas, we take a venous blood gas, we figure out what the difference is, we plug it into this equation. I'm skipping about 20 steps here just to let you know. And we plug it into the equation. This is the Fick equation. And if I rearrange this entire equation, believe it or not, I can, first of all, I can figure out what my VO2 is if I know what my cardiac output is. Or conversely, what I can do is I can measure what my VO2 is in lots of different ways, measuring what I breathe in, what I breathe out, plug it into an algorithm, and I'm going to know what my VO2 is. I can measure what my AVO2 difference is, and therefore I can calculate out my cardiac output. We do this whenever we're trying to figure out whether or not we are meeting our patient's needs. It's a complicated way of doing it, but it absolutely is useful. You can use it for everything from energy expenditure and determining what caloric intake needs are, or you can work it backwards and determine what your cardiac output is. We'll talk more about that at a different time, and I'll explain it in more detail, but that's just a quick overview. Any questions? Thank you very much for listening, and again, apologies for the technical difficulties.
Any questions for Leanne? Okay, so we'll resume at 11 o'clock, and Leanne will be back to us to talk about non-invasive ventilation. Thank you, Leanne.